Hi everyone. It's 5:30 Pacific time, so we'll go ahead and get started. My name is Kendall, and I'm going to be your host this evening. So first off, welcome, and thank you all for joining us. Tonight is a really special webinar. Not only do we have a record number of attendees, thanks to all of you, we also have a guest host that we're thrilled to introduce. And to say he'll be covering a topic our customer base has a lot of interest in would be an understatement. So even though the Carifree system is officially intended to treat dental caries, we know that there's a growing awareness around the components that also work to successfully treat perio. And that's what we're going to be focusing on tonight. But before I introduce our guest, let's take care of a few housekeeping items. And sorry, I know these are the boring things, so I will try to go through them quickly so we can get to the good stuff. We're scheduled for 60 minutes of content and 15 to 20 minutes of Q&A at the end, depending on how many questions we get. I encourage you guys to stay on for the entirety of the presentation so that you can engage live with our presenters. But if it goes long and you must leave us, we understand, no worries. You can disconnect at any time. We're going to be sharing a recording at the end, so you'll have the full version to watch later on. Speaking of Q&A, we'll be looking for your participation throughout the session, so please don't be shy. There will always be a chat box or a Q&A box somewhere on your screen. We may pose some questions to you, but you're always welcome to type your comments and your questions to us as well. Also, if you have any technical difficulties during the session, you can seek help in any of these boxes. We have a team of people that are ready to assist you. Okay, with those things out of the way, it is my absolute pleasure to introduce Dr. Doug Thompson, our guest host for the evening. Dr. Thompson is an internationally recognized speaker and has completed hundreds of hours of continuing education at the Coy Center up in Seattle, Washington. I guess it's up for us here in Albany, Oregon. In 2015, he accepted a part-time faculty position teaching about personalized periodontal medicine, and in 2016, he added the wellness dentistry topic to his teaching role. In 2015, he also founded the Wellness Dentistry Network, which is a community of dentists with a keen awareness of how oral conditions affect whole body health. He owns and runs an established private practice in Bloomfield Hills, Michigan under the name Integrative Oral Medicine, and he's absolutely an industry expert in periodontal medicine, continues to push towards a better overall standard of care for patients. He's been a great partner to Carifree, and I have to say we are very proud to work with him. Also on the line with us, we have Dr. Cooch joining the conversation. You all may know him as the founder of Carifree. Dr. Cooch also has an impressive resume, and we're lucky to have him as our resident Canberra expert. He's published hundreds of papers in journals. He acts as a scientific advisor on dental caries for the Coy Center. He reviews for multiple journals, including JADA, Compendium, Inside Dentistry, and he still finds some time to practice a few days a week here in Albany, Oregon. So the bios I've just read only begin to scratch the surface of what these two have done for the world of dentistry. We're excited to have both of you on together tonight. This is a rare and great opportunity. So Dr. Cooch and Dr. Thompson, the stage is all yours.
Hey, thanks. And thanks, Kendall. And Doug, I just want to thank you for helping us kick off our webinar series for the year. You and I go back a very long ways, and the thing I love about you is everybody that knows me knows my passion for dental caries, and what I love is your passion for periodontal disease and oral systemic health, which is very near and dear to us all. So I'm going to stay out of your way tonight. I know you have a lot of material to present, and I'm excited to hear it. So I'll be right here. Doug, take it away.
Thanks so much, Kim, and hey, thanks, Kendall, for the great introduction, and thank you all for joining. I know a lot of people have given up some time for this tonight, so let's, to your point, Kim, let's get started. One of the things I want to make sure that we do is everybody understands the current model of periodontal disease progression and kind of how it happens. And one of the things that I learned early on is that looking at how periodontal disease happens and looking at this green box here that I'm taking this arrow around, this green box is basically a microbial challenge box. And that microbial challenge is made up of yeast and viruses and bacteria. And without that microbial challenge, periodontal disease doesn't happen. But interestingly, what happens, once that microbial challenge hits the system, we all have a very unique host immunoinflammatory response. And that response is made up by our innate risk factors, things we were born with, like our race, our ethnicity, our age. We can't change that. But then it's also affected by our acquired and environmental risk factors. And those are things we can control, like smoking and diet, and sleep, and hydration, and nutrition, and exercise. All these different things go into how we respond to this challenge. And it's really this unique host immuno challenge that determines whether this disease stays confined to the gums, and it's just called gingivitis, or whether there's a whole series or host of cytokines and other inflammatory things that go on and cause a dysregulation of bone metabolism. And if that happens, it's called periodontitis. And then we have clinical signs of the disease that we can see. So what I thought about very early on when I looked at this disease and I saw this model was, what if I could do a better job in this green box? What if I could do more here? Because there wasn't one paper that told me this disease starts without this microbial challenge. And that's, in fact, where we have spent a lot of our effort looking at. Now, we are going to be growing a lot in this host immunoinflammatory response box in the future. We're working hard right now on things we can do to modulate the response to the microbes so we can even change disease progression further. So that's what we're hoping to and looking to do in the future. But here's the bottom line about this disease. This disease is biofilm induced, and it's modulated by the host. Without biofilm, we're not going to get the disease. That's great news for us, so we're looking for great ways to control the microbes. So tonight I want to outline this disinfection strategy that we somewhat stumbled upon, but now it's become very solid for us. And then I want to review a little bit of literature that supports the use of these products and how it happened to us in practice. So I'm going to hit the disinfection protocol quite early. So the other good news for us is in the microbial challenge box, we started to get some companies that provided testing so that we could move away from culture growing, and we could move away from microscopes to look at the microbes, move away from using those as the sole way to look at these. And we started to get testing companies that came on the block and started to develop these tests for us. We have 3 nice testing companies now. They basically test for the presence of certain microbes, the concentration of microbes, and one of the companies actually tests for candida and for strep mutans. One of the other companies has a new caries test out that maybe Kim and I can discuss at some point at another time, or maybe even a little bit later tonight. So this microbial challenge box is great, but what did I have the ability to do in maybe 2008? I could measure it, and I could start to look at the microbes and see what's in that box. That gave me a whole new lease on periodontal disease. So what we were shooting for, and what I've learned over the years of treating hundreds of cases, is that we would take a case basically that had a certain high number of pathogens, active periodontal disease based on a periodontal chart. We would treat this to some clinical endpoint, and our criteria for successful treatment was 0 bleeding on a perio chart, and we had to have an altered microbial profile. In other words, if you didn't see an alteration in this microbial profile, maybe your treatment wasn't so succinct, because I was seeing lots of better perio charts, but I wasn't seeing better clinical endpoints of disease for long term, and that was disappointing to me. When I started to use microbial profiling, I started to realize there were other benefits to the patients. It helped me in communication. It helped me in treatment acceptance. It helped me in having this opportunity to discuss not only our unique host immunoinflammatory response, but what goes into that response, and this was really the genesis of the wellness practice. It's really how it started. The biggest thing I learned throughout this entire process is in my practice, in my hands, using a very detailed disinfection protocol that I'm going to go through, it takes my average patient 4.5 months to maintain periodontal stability based on the definition that I just gave you. 4.5 months totally changes my clinical consults, and it totally changes my patients' expectations as to when they're going to get better, and that's given me more time to treat the disease, and it's created patients that are more patient and more diligent at working at the disease. That's been an amazing revelation for me. So it started really with this case that I treated, and I treated it conventionally like I learned in dental school. 4 quadrants of scaling and root planing, chlorhexidine rinse, and I had the patient back in 6 weeks for what I expected to be a fantastic hygiene phase completion appointment. Well, I did see a better Perio chart. I saw a much better Perio chart, but when I measured the microbes, I saw no change in the microbial profile. And I knew from past cases, and I knew from past experiences that if I didn't alter that microbial challenge box, this disease was going to come right back with a vengeance, and I would have a hard time maintaining long-term stability. So we started to think about what did we need to do, and we needed to take a much more significant disinfection approach. So this is the disinfection protocol that we came up with, and I'm going to break it down, and I'm going to give it to you in both verbal form, but you're going to get a handout with this on as well. If you download the handout, it's very detailed. So I want to hit the high points of what this is. This is how we disrupt biofilm in the office. And the goal in the office is to do this. We have to disrupt the biofilm or remove it, and we have to allow a healthy balance. And again, Kim's authored a beautiful book about caries management called Balance. If you haven't seen it, you have to get it, because this is what it's about. It's about maintaining a balanced biofilm that doesn't initiate this host immune response. That obviously can do what? It can lead to inflammation and tissue breakdown. And we're going to do that in the office. Well, we have a lot of cool tools to do that in the office. We know we can work on the teeth, so we're going to do that mechanically. We can do it with piezo, Cavitron, laser, hand instruments. You can add ozone, you can add photodynamics, you can add all kinds of things you want. But the idea is you have to mechanically disrupt the biofilm on the teeth. We also have to do something in the sulcus. We know from studies that I'm going to review with you that it's really prudent to use potent disinfectants at every treatment session, every maintenance appointment, but for sure during your disinfection. So we got to answer the big question, what's that disinfectant going to be? We also know that the tissues or the fluids that bathe the teeth, if we can get either time-release antibiotics or some antibiotic in those fluids, we can have a better outcome. And then we can't neglect the rest of the mouth. We need to think about what's going on in the rest of the mouth, and do pathogens live in the rest of the mouth? And I hope by the end of our time together we'll have good evidence to show that they do. So we got to think about the cheeks, the tonsils, the tongue, and the rest of the oral cavity. Now, I can assemble some great periodontal therapists. I can put together some great instrumentation, and I can do this in the office beautifully. I can do this in the office beautifully, but here's the rub. I got to get the patient to do this at home. How am I going to do that? So here's what we have to do. We have to give the patient a mechanical methodology at home. The exact same thing, a mechanical methodology. And so there's many ways to do that. Power brushes, water picks, proximal brushes, interproximal cleaning aids. We also want them to manage the fluids in the sulcus. So that's going to continue to be irrigation. We can add additives to the irrigation. We can do things to basically beef that up. We can use trade delivery systems. And then we have to get the patient to do something in the rest of the mouth. Some kind of significant antiseptic, antimicrobial in the rest of the mouth. How long? Until we get the biofilm balanced. I don't know how long that's going to take. For some patients, it could take quite a while. For other patients, it's going to take 8 weeks. For some patients, it's going to take maybe close to a year. But we got to continue to work with these patients until we get the results we want. So again, it's home care on the teeth, the tops of the teeth, in between the teeth, in the sulcus, in the cheeks, tonsils, tongue, and the rest of the oral cavity. If you do any one of these without the other, you will be less effective. And so it's clear, and I'll show it in the literature later on in the presentation, we need both mechanical debridement and we need pharmacotherapeutics. And if we use one without the other, we will not be successful. There's no rinse that you're going to rinse away periodontal disease without some help doing something mechanical. So here's what we did for this patient where we didn't get the bacterial movement that we wanted to. We attacked the bacteria mechanically. We attacked the bacteria in the sulcus, and it's written on the screen, but we're going to end up using obviously the product that Kim's company created. And we can use, there's other disinfectants you can test. If anybody out there says, oh, I think I can do this with some other disinfectant, please just do me one favor. Just test. You can use any disinfectants you like, but just test, and I want to give you the rationale why we have chosen the Carifree product. And then orally, we want to do something on the rest of the mouth, so we want to get this rinse. We're going to do this rinse for at least 2 months. That's going to be our first evaluation. Then we're going to go to some other chlorine-based rinse once the patient stabilizes. Systemic antibiotics, we're going to use these based on a microbial report. And home care, I've already reviewed some of the items we're going to do in home care. I do want to make one quick comment about the occlusion. The occlusion will not cause periodontal disease, but an occlusal dysfunction issue will aggravate an existing disease. We spend an entire week and more at the Coy Center talking about occlusion, and if anybody hasn't visited that institution to look at that, it's a must-do for sure. The goal is to ensure there's no interferences that cause rocking or pushing or any kind of lateral deflection on the teeth, and this, in fact, is not the patient that I treated, but this is an idea of occlusal rebalancing, not the focus of today's webinar. So we did this treatment for this patient. We did exactly as I outlined, and again, I have it written down for you, and I outlined. We'll talk about it a little bit more in detail as we review some of the literature that supports this idea. And the report for this patient shared that we should put him on metronidazole and amoxicillin for 7 days, and we put him on Periostat because this patient was a little bit of had a half a pack smoking habit at the time. So again, we did all this work. We requested a 7-week reevaluation, and we had him come back in. Now, the pockets were decreasing nicely. However, there's still some bleeding. We learned the criteria needs to be 0 bleeding, so we wait. We let him go out another 8 weeks, and we bring the patient back in to reevaluate, and we look and see what we have at that time. Now, one of the things that I want to share with you, if you use the Carifree product, or if we use a dilute sodium hypochlorite and even some chlorine-based products, we might get some staining of any residual pellicle. We might get a growth of some other opportunistic commensal bacteria, but we'll get a little bit of staining on the teeth. This is a little bit like we get with Paradox, and this can buff off. Hygienists can usually get this off really well. And it acts as a little bit of a disclosing solution for us to determine where the patient can do better plaque management. Just want to make you aware that happens. So I've written this out for you in great detail, and I wanted to bring this right in the beginning of the presentation so we could spend the rest of the presentation talking about where does the science support this, how did we figure it out, that kind of thing. So I just wanted to reassure you I've written it down. So item number 1 is about the occlusal analysis. Item number 2 is about our mechanical disruption. Item number 3 is about what we're going to do what we're going to do with the bacteria in the pockets chemically as far as irrigation, how we're going to irrigate. We can come back later and spend more time on this, but I want to make sure that everyone sees that we use a 23-gauge side port cannula, and we irrigate all the sulci twice after scaling and root planing. We also do this after every periodontal maintenance procedure. Very, very important to do this. And again, we're going to be using sodium hypochlorite to do this. A dilute 0.2% solution of sodium hypochlorite. Also, item number 4, attack the bacteria in the rest of the oral cavity. This is really significant. I never thought about this, but it's very important to do this. And attack the bacteria, again, in the bloodstream and cellular fluid by using our chemotherapeutics with systemic antibiotics as recommended by the salivary diagnostics or our molecular diagnostic report, depending on which one you use. And then personalized home care. I can't emphasize enough that we have to personalize home care. I used to just give people the same things. I'd say brush and floss more, you're not doing a very good job. We have to totally personalize home care to provide the patient something both mechanically and chemotherapeutically that will fit in their house, in their life, in their circumstances. So we really have to customize this, and there's a lot of different ways we can do that. And then this is key. Keeping our patients on a tight, very tight 8-week reevaluation. You could even bring patients in at 4 months or 4 weeks and have some repetitive touching of the biofilm. Very tight 8-week cycle until after scaling root planing until there's 0 bleeding. And I want them on a very, very, great rinse at that time. They'll help remove pathogenic bacteria. Now, some people may think you can remove all the bacteria. That's virtually impossible. The commensal bacteria start growing by the time your toothbrush hits the toothbrush holder. And what happens is the commensal bacteria outgrow the pathogenic bacteria so fast that what you're doing is you're changing the environment to prevent the growth of pathogenic bacteria. You're only doing this until you maintain great balance. Once you maintain great balance, now you're getting rid of the rinses, you're getting rid of the harsh antimicrobial rinses, and you're going into a much easier, lower potent maintenance rinse. So there's no way you're going to eliminate all the bacteria in the mouth. It's virtually impossible. So here's what happened after a very much total mouth disinfection approach. Pockets were still reducing nicely. His Perio chart looked fantastic. These are when these patients will come back and they'll tell you, Doc, my mouth feels different. It just feels different. Something feels a lot better. And so what you see on the right of your screen is you can see the pre-treatment and the post-treatment report after my conventional scaling and root planing. And after this total mouth disinfection approach and debridement, here we have a changed microbial profile. I was so excited to see this because now this correlates with how he was feeling, what I was seeing, and this was very helpful for the patient and for me to see these metrics. Now, the reasonable question is, how long does it stay that way? How long can you keep it that way? That's the idea. So here's what we learned. We looked out, and I decided we would measure this patient yearly. So 2 years, 2 months post-treatment. No additional therapy other than just maintenance appointments, changed home protocol. And so now we have the patient's pre-disinfection metric. We have his post-metric that shows periodontal stability along with Perio charts with no bleeding. And in fact, at 2 years, 2 months, we still see a very changed microbial metric over the initial bacteria report. How about 3 years, 4 months? 3 years, 4 months, we still see the exact same thing. We see a very altered microbial profile, no additional treatment, just basically supportive periodontal therapy, irrigating around the sulci every time we see him at periodontal maintenance, and we'll talk about how we handle the maintenance procedures coming up. How about 4 years, 3 months? 4 years, 3 months, exact same thing, still a very altered microbial profile, very nice results. 5 years, 4 months, he had quit smoking, so he got him into a smoking, we talked to him about health. This is the other thing that happens. As we go along and talk to our patients throughout treatment, as they get better in other areas, they'll ask you for help in other areas of their life. And this is another reason we developed tools in our network to help guide patients to help in other areas of their life. They really engage with our clinical team, and it's really nice. So again, a very altered microbial profile. 6.5 years post-treatment and 8 years post-treatment, we still have beautifully altered microbial profile. And now I've been blessed to collect 9-year post-treatment data on this patient. And so for 9 years, we've changed the microbial profile with systemic antibiotics one time back in 2009 and nothing other than periodontal maintenance. So this is a really, really interesting case that let us know that we have done a great job managing the microbes for this patient year after year, appointment after appointment. And the message that I want to send is, if all the literature is true, which I totally know it is, that these high-risk periodontal pathogens have effect on vascular biology and the vascular system, what's the benefit to cardiovascular disease, to Alzheimer's disease, to colorectal cancer, to the 56 other diseases that these periodontal pathogens are now cross-referenced to? What's the benefit of keeping the patient not exposed to those pathogens for all those years? It's an amazing benefit for the patient. It's a great health benefit. So as we talk more about what personalizes this infection for patients and what changes the way patients respond, it comes down to two things. It comes down to differences in the microflora composition and obviously these host modifying factors. So what does our disinfection protocol and what does our post-treatment protocol allow us to do? It's allowed us to change this microflora composition, make a change and keep it changed for a long time. And so now what we're trying to do is we're trying to learn more and more about the microbial challenge, about how to manage the microbial challenge. And Kim and the Carifree company has really helped us do that. And we're trying to gather more data about this at the microbial insult level, and we're trying to grow our options for how to treat the immune response level. So that's what we're trying to do here. And in 2012, this beautiful paper from Jorgen Slotz came out. It's called Low-Cost Periotherapy, and this paper really started to help us understand what we were doing and why we were getting the benefit we were getting. And so what I'm going to do in the upcoming slides is paraphrase excerpts from this paper. This is a must-read if you want to understand oral rinses. It's an absolute must-read, and it's a really great paper. So the goal, what Dr. Slotz tells us, is to achieve an environment free of pathogenic microorganisms. We're trying to do that in caries, and we're trying to do that in periodontal disease. What does it take? It takes two things, mechanical debridement and pharmacotherapy. I found that out. The Slotz paper totally confirmed that for me. And these are both important components of perio treatment, and they would also be important components of caries management. And what's the goal? We're trying to either eradicate, suppress, or alter this combination of pathogens as it relates to gingival health and immune response. And I can tell you that routine scaling and root planing or rinsing without the other is going to have little effect long-term on this disease. So in the paper, Dr. Slotz evaluates some rinses, and he evaluates rinses based on their effectiveness, their antimicrobial status, and this is what I want to bring to your attention is the summary of the information that confirms that we actually selected the right rinse back in 2009. Dr. Slotz tells us in his paper that the bacteria, that periodontal disease is made up of gram-negative and gram-positive species. It's made up of some of these high-risk pathogens and some other pathogens, but it also contains candida. It also contains viruses. So one of the things that we do in practice is we do employ virus testing sometimes, and we use yeast testing sometimes if we think there's a yeast component to the infection. So we want something that will really treat all three. That's the idea. So here's a couple key concepts. There's 700 bacteria in the mouth, a lot of species for sure. We know that the bacteria are organized in complex biofilms, and the biofilms are protectionist. They protect them from the antimicrobial treatment. They prevent them from removal from other things. So these biofilms are hard to penetrate and take a while to alter. We also know that antimicrobial agents are becoming more and more popular in treating the disease, and whenever we have treatment that's not successful, we have to think about other kinds of treatments and adding other things if we have therapeutic failure. So what I'm trying to share with you is these tests and these microbial tests that we use, they don't give me antibiotic specificity. They don't, they give me some information, but they don't give me all the information. So if you have a patient that you've treated with antibiotics, you've treated them and they're not getting better, start thinking about viruses, start thinking about yeast, start thinking about something that you targeted that really wasn't the main cause of the infection. Another key concept is some of these bacteria elude removal. That means they don't live where your scalar is. They elude removal either because they have very high rates of reinfectability if you don't suppress them for a long time, or they're not where you're scaling. And so there's quite a few of these, and Dr. Slotz reminds us of that. I also know that calculus has to be removed from the teeth. However, it doesn't matter to me if you got the Golden Scaler Award in dental school. We have great studies that show that if you give periodontists all the time in the world to remove calculus, when you have pockets in excess of 5 millimeters, 5 to 6, and 6 millimeters, you are not getting all the calculus off the teeth. So there's going to be some limitations in scaling and root planing. We also know that calculus acts like a bacterial coral reef, or like a coral reef for bacteria. It's just basically a coral reef for bacteria. It's very harmful. So I started to look at calculus, and I know when I remove calculus, or I typically know what happens around this calculus, like you can see on the right, we get this band of erythema and inflammation. You remove the calculus, it bleeds. A few days later, it heals up, looks great. So calculus is important. That's what we're trying to do with our mechanical debridement, and that's what we want the patient to do at home. However, this case was very critical for me for another level of understanding. When you look at the bacteria chart on the top of the screen, you'll see a certain bacterial population. The bacteria chart on the bottom of the screen is post-treatment. And so what I see on this one is I see the exact same pathogens, but I see a reduced concentration. So the treatment for this fellow was interesting, and this proved the point for me. I actually removed his dentures. He didn't have any teeth. So you might ask, how do I get a report after the removal of the dentures with still a pathogen load? I had totally overlooked this fact. I overlooked the fact that these bacteria don't just live on the teeth that I'm scraping. They reside for years in other parts of the body, like the cheeks, the tongue, the tonsils. So we have to do something in the rest of the mouth. And I spent lots of time talking to many scientists about the folate papilla of the tongue, the tonsillar crypts, and where these bacteria hang out. And in my early treatment, I was not treating these areas. And when I put the patient on chlorhexidine for a couple of weeks, I was not treating these areas long enough. So we needed to treat it much, much more robustly. So we want to use some powerful microbiocidal antimicrobial. That's what we have to do. And why do we have to do that? Or why are these good to use? They don't interact with prescription medications. You can swish and spit. They practically eliminate all the risk of antibiotic resistance. They're very important in treating oral biofilm infections that need to be worked on over a long period of time. They are also will work on biofilm infections that are unresponsive or protected from even the antibiotics that we run, even when we disrupt the bacteria. No risk of antiseptics getting into the gum tissue and going the other way because there's a positive pressure of gingival clavicular fluid, so I'm not worried about that. Now, what antimicrobials? We want to use one that is basically called a halogen-releasing antiseptic or an antimicrobial. And if you remember from the periodic table of elements in high school, there's a very reactive group of species way over on the left of the periodic table. And that's fluorine, chlorine, bromine, and iodine. And if you think about what we use in our swimming pools, spas, food service, our hospitals, it's one of these products. These are the best disinfectants. So iodine and chlorine-based compounds are some of the most microbiocidal agents that we have. Fluorine doesn't act very much on bacteria, helps a little bit, but not so much. And bromine's way too toxic to use in the mouth. We do have some bromine spas, but we don't use bromine in the mouth. So these are a really nice, this is a really nice group of disinfectants. So we want to look at and evaluate and see what Dr. Slotz found when he looked at povidone iodine, dilute sodium hypochlorite, and chlorhexidine. We want something that has extra wide spectrum of activity and that can adjust this virucidal, fungicidal, and bactericidal biofilm even with a short application. That's what we're looking for. We want something that works quickly, and works prudently. And we want to use this in addition to scaling and root planing. So let's look at iodine. Iodine's bactericidal, fungicidal, and virucidal. I love that. That's what I need. And also, but however, Dr. Slotz reminds us that it might not reach all bacteria in biofilm. We know that's true, though, for almost any of the rinses. It's generally povidone iodine, 10% is what's available. It's generally non-toxic, non-irritating. However, it's very staining. We also know that it's under acidic conditions, it's highly, it has high antimicrobial activity. But if you have a lot of blood or sputum, it will inactivate that. And it really needs a set time. It really needs a nice 5-minute set time, and this creates a problem for us. We have gingival clavicular fluid turnover every 90 seconds. Pretty hard to get something in the salt because it's going to be in there for 5 minutes. Also, iodine can create some allergic reactions. We can't use it in patients with thyroid issues. Shouldn't be used with pregnancy or breastfeeding. So for these reasons, iodine's not looking so attractive to me. I'd like to look at the next rinse that he evaluates. But there's one important point that I want to share with you before I leave the iodine discussion. And it happened to be with iodine that Dr. Slotz saw this important concept that we apply in all of our periodontal maintenance procedures. He looked at pockets that were irrigated with iodine alone and iodine plus scaling and root planing. And what he saw was a significant increase in the number of pockets that had a 95 to 100% reduction in subgingival pathogen counts up to 5 weeks after treatment. So when you have your patients in for scaling and root planing, it's really, really interesting. It's really important for you to irrigate these pockets because chemically, after you've mechanically disrupted the bacteria, chemically, you're going to alter the pathogens and you're going to alter the flora in that pocket for maybe up to 5 weeks. And what we're trying to do is again, keep these pathogenic bacteria at bay. You already know with your periodontal disease patients, they have a susceptibility to these bacteria. That's why they need this treatment. I do not provide this on my healthy prophy patients. My patients that do not undergo periodontal procedures would not get this service. And this is why we charge more for periodontal maintenance. How about chlorine? One of the most potent antiseptics we have against bacteria, fungus, and viruses. That's beautiful. We do make this at a cellular level in human neutrophils. Nobody's allergic to it. It's obviously caustic, or it's obviously skin irritating when it comes out of the bottle at that concentration. That's not how we're going to use it in the mouth. It's not a mutagen. It's not a carcinogen. It's a very common product that's been used for hundreds of years. Hospitals, animal facilities, human drinking water, has a high pH, which is really nice because pH shifting of these acidic environments is also very important for us to do. It too can be inactivated by organic material, so it's nice to rinse before we lavage the sulci with this. We know it deteriorates with heat and light. I do want to ask Kim at the end of the presentation. I want to have him hold that thought, but I want to ask Kim if we were to put this in clear bottles, or if our sodium hypochlorite products weren't in opacious bottles, how long would they last? And then also we want to be aware there's a shelf life, so we don't want to, you want to make sure we keep fresh stock of this. But it has a broad antimicrobial activity, 80-fold decrease in biofilm endotoxin compared with water alone. It's a great product to use in the proper dilution. Even the American Dental Association has said dilute sodium hypochlorite can be used as a mild antiseptic mouth rinse. It's no problem putting it on mucous membranes. Doesn't cause tooth erosion because of the pH. Doesn't corrode titanium implants. No detrimental effect on periodontal healing. And this sodium hypochlorite has no contraindications to use. Really good news because we started using it in our disinfection protocol in 2009. I did provide this slide for you, which you can go back and look at, because you can look and see that they tested very low percent solutions of this that was very effective. And again, Jorgen Slot's, remember, the paper was called low-cost Perio therapy. So Dr. Slot's crate has some recipes in there for how to make the product, how the patient can actually make the product themselves at home. So you can share that. If you have patients in low socioeconomic areas, they can't afford much, they could do a lot better with the dilute sodium hypochlorite product. So this was the only commercially and professionally available chlorine-based rinse on the market for me when I started the disinfection protocol. It was my go-to. It became my go-to, and I can tell you it works. It works beautifully, and we've been using it in all of our disinfection protocol, throughout time here. We also know that there's some other additives that help us. We have xylitol, we have fluoride, we have pH, high pH, and then we have the germ killing of the sodium hypochlorite. How about chlorhexidine? Chlorhexidine discussion is going to be pretty short. I've really dismissed this from the practice way back in 2008. And chlorhexidine it can be bactericidal, fungicidal, and can affect yeast. However, some periodontal bacteria are only moderately susceptible. We have had some allergic reactions from chlorhexidine. It too is inactivated by organic compounds. It can impair fibroblast healing, which I absolutely don't want. It is not a friend of normal periodontal healing. So for those reasons and others, chlorhexidine's out. Fluorine, as I said earlier, I'm not going to spend much time on this because it has little microbiocidal activity. However, it does, we do use it for root sensitivity, and we do use it for management post-scaling and root planing. And so our patients are usually on at least a tube of some high fluoride product. And one of our favorites is CTX4. And I do have a slide showing some of the other products that are out there that are high fluoride products, because we know we have some choices. And so you'll use what makes good sense for your patients. Hydrogen peroxide only has a modest effect. I have people ask me all the time, what if I put hydrogen peroxide in the water pick? This is liquid hydrogen peroxide now that we're talking about, because I'm going to show in the not too distant future that the hydrogen peroxide gel can be beneficial in the maintenance phase. And then quaternary ammonium compounds, only a moderate bactericidal activity. We have some natural products like grapefruit seed extract. That's a ammonium quat compound, but again, very modest effect on periodontal disease. Time-release antibiotics are also, they help with inflammation. I don't think we're getting such a great response with connective tissue attachment. These carry a high acquisition cost. However, in many of my early cases, we used Arrestin in all pockets greater than 5. We use these products, these time-release antibiotics. So I need to be complete in my discussion about that, and we still do use them today. Systemic antibiotics, the literature is clear that there's bacteria that are very stubborn and that they're going to be able to be suppressed by systemic antibiotics. However, untreated, these bacteria can persist in periodontal sites for decades. I found this very interesting, especially when I was thinking about disinfecting the tongue and the rest of the mouth. So we also know that if you're going to use antibiotics, it should be based on the identification of the pathogens, not just anecdotal. It would be much better if you could target the pathogens that you're trying to treat. So the companies now do provide recommendations, and the idea is we would like to test, find out what we're treating, and allow more targeted therapy when we're using systemic antibiotics. I'm not going to talk about it tonight on this particular webinar, but I want to just remind you, please cover all your patients that you're giving antibiotics to. Please cover all of them with a very good, high-quality gut probiotic, preferably one that contains the friendly yeast called Saccharomyces boulardii. Also, another study looking at the systemic antibiotics as an adjunct to mechanical and pharmacotherapeutics, very, very effective, and we do get better results. But again, here we remind you that antibiotic-associated diarrhea and C. diff are our two big concerns. Using very good blended probiotics, I've had no problem over 10 years treating most of my Perio case type 2 and above cases with systemic antibiotics. So the conclusion of the Slott's paper: mechanical debridement, pocket irrigation, potent antiseptic, treating disease with systemic antibiotics. It appears that this dilute sodium hypochlorite and sometimes iodine or other rinses, these are the rinses that we need to use for our disinfection protocol, and we need to change our expectations for when patients are going to get better after our periodontal disinfection protocols. So again, this is a very, very effective rinse. There are some new rinses coming out on the market that we're going to evaluate. I'm bringing it up only. I want to show a brief slide for the people looking at the video later, but this is molecular iodine. I'd really like Kim to be aware of this and look at this product, but this is molecular iodine, and it's 300 times the strength of povidone iodine, and it has some other benefits, so this is currently under review. And again, this company also has some strong arguments for why we no longer use chlorhexidine. So these are similar things that Dr. Slotz has said, so I wanted to share that with you as well. There's also rinses. This one is silver nanoparticles. There's quite a few different rinses coming out. Again, if you're going to test any of these, please use metrics. Test these rinses. Don't just tell us the patients look better. We need to see microbial metrics that show that you made a difference in the microbial profile. That's what we need to see. We know patients are more effective with oral irrigation, so in our maintenance protocols, we want to make sure that we include oral irrigation, and there are benefits to oral irrigation. shear force for mechanical removal, more effective than brushing and flossing alone. So please think about using oral irrigation. And I've provided a handout for you at the end of the lecture for oral irrigation options, because what we get to do with these irrigators is we can enhance them. We never put this in straight, but what we can do is we could put an eyedropper full or some small amount in, and we can use dilute products in these water pick reservoirs. Also, there's some maintenance rinses that are much less harsh than 2% sodium, 0.2% sodium hypochlorite, so we can use some of these maintenance rinses, and we have some good rationale for using maintenance rinses that we can control the freshness of. So we have some favorites in that regard. It's well listed in the disinfection protocol for you that I've laid out for you. Be aware of any commercial rinses that are highly acidic, probably not the best choice, and be aware of rinses that might not have the potency of others in their same classification of products. So we want to be careful with those. Yeah, and this is the sheet that I've provided you, and these are methodologies to enhance the effectiveness of the water pick. That's really, or hydrofloss or well floss. There's many different types of irrigators now on the market. So the foundation of home maintenance is going to be mechanical. It's going to be chemical, and it's going to be softer than what we do when we're doing a treatment, but we're still going to use different products that the patient can use that works for them, and we're going to take care of them. And here's the very important comment. We're going to shorten the recare, and we're going to see them back more frequently, or we're going to enhance their rinses or enhance their home care at the slightest regression of disease. How do we determine that? We measure bleeding in the periodontal charts. That's how we determine that. So again, I've provided these handouts for you. We'll be happy to field questions here in the upcoming minutes. For maintenance and for treatment, you can try. I've been very successful with this with maintenance, but it's using a 1.7% hydrogen peroxide gel in a medicine carrier. And the idea is these medicine carriers are now going to be used with many, many more compounded medicaments, and that's the future for us, is learning how to customize these things in these carriers. So as I move and start to close this program, you totally can be sick. You can have a cold with a healthy mouth, but I can guarantee you this: you cannot be healthy with a sick mouth. It's absolutely impossible. If you have a sick mouth, you're going to have some downstream biomarker that's affected by that. So I want to start to close with a couple ideas about systemic health. We know that many adults have periodontal disease. That's what the literature says. We also know that it's becoming clearer and clearer that the mouth has to be healthy. It's a gateway to a healthy body. But we want to make sure that everyone understands how this happens with our vascular disease. And what it really is it's inflammation. And our whole world started to learn about it in 2004, about how inflammation was a secret killer. And now we have great works written on this concept that says medicine is redefining heart disease as an inflammatory disease of the blood vessels. What's the good news for us in dentistry? We're the only ones that can treat these bugs that live in the teeth that cause these problems. What do the bugs do? The bugs affect vascular biology. And I want to just give a brief close about how I've been made aware of this and what's going on at the vascular level from these bugs. Most of us know or have heard of Brad Bale and Amy Doneen. They wrote Beat the Heart Attack Gene. This is a must-read. It should be sitting on the windowsills in your operatories. And when people look up and ask me, why do I have this book? I tell them because bugs that live around the teeth can affect the vessels that your body, that services your heart and your brain. And you can get, the bacteria in the mouth can be the initiators of heart attacks and strokes and vascular disease. And what Brad and Amy have let us know conclusively is physicians cannot manage this disease comprehensively without a thorough oral inflammatory illness evaluation. When they send someone to you for evaluation, they're going to expect that you know how to control the biofilm. That's what we have to do. And so I want to just remind people that we have great literature that when we look at a healthy vessel over here, we have great literature to show that periodontal pathogens have an effect on the thickening wall of the intima. We know that periodontal pathogens have an effect on the atheroma process. We know periodontal pathogens have an effect on the instability of holding the plaque in the vessel and allowing a sudden stroke or heart attack. And the beauty is there's biomarkers that we can measure as a result of vascular disease, and we can look at these biomarkers and we can make a determination of how well the patient's doing maintaining the inflammation level. And so it's important to start to learn how to incorporate this kind of concept into practice and to have someone help you manage the patients this way. And we use, through our network, we can measure some of these biomarkers because we are trying to tie inflammatory illness diseases like periodontal disease with medical biomarkers and show that our management of the biofilm is changing the effect those biomarkers have on our body. So I can tell you that microbial profiling is incredibly valuable to periodontal disease management. It helps us a lot of ways, how we communicate with the patient, how we educate the patient, our treatment effectiveness. It tells us what pathogens are there. We know that these disinfection strategies have to address the entire mouth and not just the tooth surfaces, and we need these potent antimicrobials, and 0.20 or 0.2% sodium hypochlorite is the rinse of choice for us, and we have lots and lots of literature to support that, that decision. So Kendall and Kim, I'd like to maybe open up dialogue and talk about how I can help answer some questions.
Yeah, thank you, Dr. Thompson. That's a lot of great content. I'm very impressed because I know you could spend multiple days talking about this and getting deeper into all of this. So I appreciate you getting through everything in less than an hour, which leaves us quite a good amount of time to have some dialogue and answer some questions. Before we get to questions, I know you mentioned throughout the presentation you had a few things that you wanted to bounce off of Dr. Cooch. So if you maybe want to do that and get some comments from him, and then with the time that we have left over, then we can get to some of the other questions.
Yeah, Kim, one of the things we do in our operatory is we have some self-leveling graduates that are not opaque. And if we put the B bottle in one of the self-leveling graduates and we put the A bottle in another self-leveling graduate, it's a very easy way for our periodontal therapist to quickly squeeze the B bottle, quickly squeeze the A bottle, dump it into a Dixie cup, and this is how we suck it up in the 23-gauge cannula. What would the life expectancy of that product be in a non-opacious container?
So, Doug, literally, when you mix the A and the B, anything is not very stable mixed with sodium hypochlorite because it's highly reactive. So we're talking hours that it would be stable after you mix it. And that's really doesn't depend, and that really doesn't matter whether you're in a clear or an opaque container.
Yeah, maybe I didn't make myself clear. We have an A clear container and a B clear container, so they're never mixed until right at the patient treatment.
Right.
So they're never pre-mixed.
Yeah. So when you mix it, I would tell you safely it's good for an hour, 30 minutes to an hour. Now, just having those in the clear container, let's say it's stable that way for days to weeks, not months.
Okay. Yeah, we use it. We go through it so fast. It's no problem. That was one of the questions that I have.
Yeah, I wouldn't think that would be an issue for you clinically. Yeah.
Nope, no problem. Okay, whatever. I'm open to, and I don't know, Kendall, if you and Kim have been taking the questions. I haven't canvassed the questions on my screen. So if you want to direct me, that would be helpful.
I would say, Kendall's got a bunch of. Yeah, Kendall's got a bunch of questions I know that have been, coming in. The participation tonight's been unbelievable. The one thing that I wanted to kind of go back and review with you real quick, Doug, that I noticed out of your presentation that's been my own also experience at treating dental caries biofilms, is that it's interesting how much these are both biofilm diseases. So it's interesting to me how many things they have in common, right? And one of the things when I first started treating dental caries, with chemicals as well, the biofilm, I thought like, oh man, 30 days, knockout punch. I started with chlorhexidine. I was not pleased with the results that I saw as I was culturing for lactobacillus. Switched to povidone iodine for about 2 years, and that was very problematic, for all of the reasons that you listed. And then I, read the Jorgen Slott's paper and looked at some of his other papers, and I thought, well, sodium hypochlorite, I'm going to experiment with that. And I thought, oh boy, 30 days, this kills everything. It helps dissolve the biofilm. Man, we have got the knockout punch here, and I'm going to fix this disease like in 30 days. And surprisingly, clinically in my practice, that didn't happen. Their gums got pinker and healthier in 30 days, but in terms of changing the biofilm that, on the teeth and looking at the caries pathogens, made progress in 30 days, but found that it was more like 4, 5, 6 months. And so I was very, you kind of validated how long it takes to change the biofilm, and you talked about it taking 4.5 months on your patients to see, progress with, with your entire protocol. And I would also share that we did a study, probably back in 2005 on school-age children, high-risk caries patients, kids in a limited protocol in Townsville, Queensland, Australia, and we did a 3-year clinical trial and found that they actually continued to improve for 2 years. And so, but then in the 3rd year, there actually wasn't any additional improvement over the 2 years. But it took us in that limited protocol at school where that's all they used was the Carifree treatment rinse there. Took 2 years to really change their biofilm. So that changed my whole concept of this is not an overnight, treatment for this disease, but it's going to take a greater amount of time than I anticipated. So I just wanted to share that because I think when we look at changing biofilms, I initially thought, oh, this is going to be easy and we'll change it, in a short period of time with all these chemicals and antibiotics, and then found it took much longer. The interesting thing about biofilms, though, which I think is also, I love seeing your 9-year, clinical results on these patients, is that once you change a biofilm, biofilms are extremely stable. So it's like, they are, unless something in the environment changes dramatically, biofilms are extremely stable and they kind of self-regulate. And so it's hard to change a biofilm, but once you successfully change it, it's also then hard for it to change back. So unless you have some major selection pressure on that biofilm, so I think that it's, once you get them healthy, as long as they continue on with a regimen like that, it's encouraging to see 9 years later that they stayed healthy. I have now 12-year results on some patients that I started treating this way with dental caries, and they've been decay-free for 12 years. So I think the answer is, instead of drilling and filling, instead of like just scraping teeth to get the calculus off, you take a whole approach to treating this disease and look at a microbial approach as well, and you can make a significant difference for people. So with having said that, I want to go right to the questions.
Okay.
Yes, thank you. Thank you, Kim. So the first question that I'll ask, this came from multiple attendees, so I think it's one that people are eager to hear about, and that is, do you guys typically see good compliance with your patients at home? And if not, do you have tips for increasing patient compliance with home care?
Yeah, Kendall, it's a great question, and I can tell you that your patients are going to understand the seriousness of the disease to the extent that you explain it to them. So when you sit down and you tell your patient, I don't know too many cancer patients who don't go on chemotherapeutics. So basically, when they understand the disease and they understand how serious this is and what the ramifications of this disease are to the system, I sit down and tell them I have one medicinal rinse. It's the best rinse on the market. It's a medicine, not a refreshment. It's going to have a pungent flavor to it. But this is the rinse that's going to make a difference in your health, and this is what you need to use until you're stable. And so we have great compliance. I've had only a handful. I've treated hundreds of patients. I've had only a handful of patients not be able to use the rinse for some reason, and for that we use other things. But this is the way you increase compliance is to sit down, demonstrate the rinse with them, show them what to do, and make sure they rinse for a full minute. And I have people now that come back and want to use the rinse. They want to use it indefinitely. Compliance has not been an issue for us, and I hear that comment all the time, but it hasn't been an issue for us. I think we have to stress the importance of what this rinse does for us. I have nothing else that I've tested that alters biofilm better long-term than this rinse.
I'd have to agree with you on that as well, Doug. And I've not seen anything that modifies biofilm like this rinse does. But I'd also say too, I do the same thing in terms of patient compliance. Have the hygienist or the assistant open the bottles, show them how to mix it, have them use it there actually, so they get experience to taste, and set them up for the fact this isn't lolly water, this is not candy, this is actually medicinal, and that it's not going to have, prepare them for the taste. And we have great patient compliance. And again, I'm like you, I have a lot of patients who want to use it every day, and there is no contraindication to doing that. So it's safe for somebody to use it every day for the rest of their life. I mean, so that's
and the other thing,
issue.
Kim, that we do is they get another taste of it every periodontal maintenance, because we're doing 2 laps around the mouth every periodontal maintenance with it, so they get it. I mean, they know why we do it. Alters the bacteria in the sulcus for up to 5 weeks, so it's great.
Yep.
I like the cancer chemo analogy. I think that's a good one, and we find that people get used to it too. So it's not as shocking, the more and more you use it, it's not quite as shocking.
Well, what I'm struggling with, Kendall, is our profession. If you look at the codes that we use to show how much periodontal disease we treat, it's well under 5%, and it's really a shame that we have a medical condition of the mouth, and we just haven't taken it as seriously as it really is. And so you are not going to walk in and out of our practice with bleeding gums and not know it. So it's really something that I'm trying to really encourage our profession to step up on.
Doug, and you bring up a really good point there, because so many times I'll hear from a patient, they have a bleeding point, and it's like, well, it doesn't bother me, right? Or I'll be at a meeting and I'll have a hygienist say, well, they only had like 2 bleeding pockets, and so we didn't do anything. And I'm like, when did that become the standard of health? If I had a pocket that bled in my mouth every time you touched it or flossed it, I would have alarms going off. But where was I when a 5 millimeter non-bleeding pocket became like the standard of health? And it's like I look at our profession, and we take this disease so casually, our approach to it, and we've been treating it mechanically for so long, and and we know what the results on that have turned out like. And now we have the information. I mean, Brad and Amy that you brought up tonight, it's causative. I mean, they have proven that periodontal disease is causal in heart attacks and strokes. It's like what you're doing, Doug, and what you're helping your patients with, and how you're changing the profession, the minds of the dentist and the hygienist, is actually has a huge impact on people's overall health and their longevity. I have no doubt about that.
Yeah, and I also want to make sure people know that, hey, where I started, when I started this, I used to wait until the disease outpaced my skill level, and then I would get really afraid, and I would refer to the periodontist. They'd say, why did you wait so long? So I was doing, 10 years ago, I was doing 99% pro fees in my practice as well. So I really want to be compassionate to people that are trying to grow their practice, and that's why I think they need some support. It's why we created the Wellness Dentistry Network. We want to outline these protocols and give people an avenue to grow into these processes. So I can understand how it might be a little intimidating, but it's really critical to start to grow in this direction, because the time is now for that.
Yeah, and I would just want to chime in here. Doug, your Wellness Dentistry Network is one of the most complete and amazing resources that I have seen on this topic, and so we're a member of that, and we love it. Anybody that I'd encourage you tonight to check that out.
Thanks, Kim,
I have
for
to
that.
say,
Thanks for what you're doing.
I just got access to the Wellness Dentistry Network, and I was very impressed with the amount of resources that you guys have posted in there. So speaking of the WDN, I switched it over to another layout. You guys probably saw that on your screen. There are links up in the top left-hand box, so you can learn more about either of the respective companies, Carifree or Wellness Dentistry Network, so feel free to click on those links to inquire more, and I'll go over that a little bit more once we're done with the question session. Number 2, this one came up quite a bit as well. The most recent one I saw was from Timothy. People asking about yeast strains. So if CTX4 eliminates pathogenic bacteria, what about good bacteria or the balance between bacteria and yeast? How does that affect it?
Yeah, it's non-selective for yeast, viruses, and bacteria. And so what I tried to do during the presentation, I tried to talk about the balance and the fact that the good commensal bacteria grow so quickly that there's really no chance for us to eliminate all the bacteria from the mouth, and you're not going to get yeast overgrowth like you can do when you have antibiotics because it's effective against yeast. So, so really, and we also have tests. We have microbial tests that speciate yeast now, and 9 different species of yeast have been identified in the mouth. And these tests, these metrics are going to keep getting better and better for us to look at. So Kim, I would defer that question further to you. And
that's a really great question, and that's one that I get often as well. And the big story in dental caries in the last 3 years has been Candida. Candida appears to be not just a common inhabitant of the mouth. It appears to be a serious player in dental caries. It's extremely acid uric. And so the 3 primary species of Candida that have been identified as cariogens is Candida albicans, obviously, dublianensis, and then also paraplosis. Now, the treatment rinse, sodium hypochlorite, is effective against everything. I mean, it kills all yeast, virus, and bacteria. And when you do that, I tell people it's like hitting the reset button. And I heard a scientist at a meeting, and that blew my mind. He said, oh, well, if you do that and you wipe out everything and take all the numbers, suppress all the numbers down, well, you get rid of all the commensal bacteria at the same time, just the pathogens are going to come back and the disease is going to get worse. And I sat there and I thought, that absolutely is not my clinical experience, and it's not even logical, because once you do that, the early colonizers that create the biofilm, the commensal healthy early colonizers, start the process. That's who they are and what they do, and they come back first. And if you've got the right environment, they do it quickly, and it's like hitting the reset button, and the healthy bacteria get a jump to get back in and get control of the biofilm. Think about this for a second. If every time you suppress biofilms with an antimicrobial agent, if you had an infection and I gave you an antibiotic and only the bad bacteria came back from that, everybody would get worse and worse until they died. So, I mean, it doesn't even hold water. It doesn't even make sense. So it's so I would just say that it's effective against all of those. And I don't know, Doug, you know better than I on which Candida species are, playing a role in the periodontal disease. But
well,
certainly,
Candida glabrata is a kind of a more opportunistic pathogen. We have some papers on that, but I think that's a lot of stuff that'll yet to come for us. And I'm happy to know which ones are significant in caries, because I've applied a lot of our periodontal strategy to the caries infection as well. I'm sad to say, Kim, I used to give kids a tube of toothpaste and say, use this, but not anymore. We have a cavity treatment planner in the network, and we really want to hit it we need a multi-pronged approach to that disease as well, as you know.
Yep. Thank you, Kendall. Got time for one more?
Yes, absolutely, we do. One from Karen. My patients want to use something natural, or they are hesitant to use antibiotics. What is the best option?
Well, that's going to be a little bit more challenging, but there are some biobotanical products out there that you can put into rinse systems. One I would recommend would be biocidin. And if your patients don't want to use antibiotics, you can get some compounded antibiotics that you could swish and spit. So beyond that, when patients start to take tools off the table that are effective for me, I have a harder time. And it's going to take a longer time for them to get well. But you would have to be relegated to all your natural products like biocidin rinse, xylitol, still a great mechanical disruption procedure, but you would have to then go to some other biobotanicals. And those I just haven't tested, and I haven't done bacteria studies. Now, to come up with this solution, with this system, I went through many different rinses. I tested all kinds of things at my expense and did microbial testing. So if you're going to test any kind of rinse, any kind of all-natural, and you find that it works and it moves the biofilm, then you're really on to something, because I haven't been able to do that. So I would love to learn. So if that happens, please call me and let me know what the recipe is.
And Dr. Cooch, did you have any thoughts that you wanted to add to that?
No, not really, Doug. I think you covered that really well. I mean, I practice here in the People's Republic of Oregon, where fluoride is bad for you and marijuana, surprisingly, is good for you. So, so I have a lot of patients, a growing number of patients, and I know that everybody that's on here tonight has the same experience that, they're fluoride resistant. Well, you take that tool away from me, and yeah, can I treat dental caries without fluoride? Yes, but it's a greater challenge, and it's going to take more time, and you may not get the same result. So as long as you're willing to accept you're creating a compromise and there's a price to pay for that compromise in terms of outcomes, I'm okay. I work for you, and I want to help you as much as I can. You're just tying my hands here and handicapping me, but again, I work for you, so I'm open to trying to help people and help them find their way back to health.
Yeah, and I can't tell you how many patients, Kim, have come in and created those parameters for us, and after we've explained the story and talked to them about what we need to do, they'll say, well, okay, maybe I'll do this. So I think we really need to experience doing this on patients that are willing, and once you see a few cases that are successful, you'll be amazed at what you can do. That being said, I'm still sensitive to the people that want to be all natural, and they want to, so we are continuing to strive to find products that we can use that will satisfy those requirements as well. I just don't have a magic recipe yet for that.
I'm working on one for dental caries, but hopefully we'll see that later this year. So
great. I'm excited now. I can't wait. So I have to call you after.
And my team wants to shoot me when I say things like that.
Yeah,
right. We'll just laugh. We'll just laugh with you. Okay, well, you two have given us a great deal to absorb and chew on. I know everyone in attendance, we got multiple comments on how great of a webinar it was, and people loved the information that was given. So thank you to both of you. A few items to mention before we conclude. If we didn't answer your questions, please look for a response within the next few days. We do try to follow up on all of the questions to make sure that we are giving you guys the information that you're looking for, so be on the lookout for that. We will also be sending out a recording of the webinar tomorrow if you'd like to watch it again or share it with colleagues. All of the links that you have found in here will be live in the recording as well. The handouts that Dr. Thompson mentioned, as well as a copy of his slides, are available in the Files to Download box at the bottom of your screen. And if you are listening to this as a recording, the links, again, will stay active for you so you can download those. If you're looking for more information on how to join the Wellness Dentistry Network or to learn more about Carifree, you can find the links on the screen in the upper left-hand box where I have this green arrow here. Feel free to click any of the links. They'll take you to directly to the respective companies. Email us, call us. Believe it or not, we still like good old-fashioned phone calls. So please don't hesitate to reach out if you have more questions. Lastly, as always, we appreciate your support. We welcome your feedback, so please let us know how you liked the webinar tonight, or let us know if there are topics that you're interested in us covering in the future. We want to make sure that this content is relevant to all of you. So I think that takes care of everything on my end. Dr. Thompson, Dr. Cooch, any last-minute thoughts from you guys?
No, Kendall, I don't see patients till 7 o'clock tomorrow. I'd love to stay, but I know we got to go. So, but I'm so thankful to have the opportunity to share this. I think it's an amazing, it's just amazing to see the health turnaround in some of our patient population. And if other people could experience a tenth of what I've experienced, it'd be amazing.
Excellent. Well, thank you so much, Dr. Thompson. We appreciate your time as well. Thanks for tuning in over on the East Coast time. We know it's getting pretty late over there for you.
Yep. I want to.
So we
Yeah,
thank you.
I want to thank you, Doug, for helping us kick off our webinar series for the year. It was awesome, as I expected, and I want to thank everybody that joined us tonight or is listening to this recording. We really appreciate your time, and we always love the opportunity to be able to help you. Thank you, Doug. Thank you, Kendall,
Thank you.
and good night.
Thank you, Kim.
Good night. Have a wonderful one.